Hi, I'm Laura Flanders, and this is City Works, the show about work and working people. City Works is a co-production of the School of Labor and Urban Studies at the City University of New York and CUNY TV. Healthcare has been and continues to be a defining issue of our time, and a major issue in the presidential election campaign. That's because different people get different healthcare in New York City and the country at large, resulting in stark discrepancies and differences in lifespans between economic groups. And so there is a reason why phrases such as universal health care, national health care, Medicare for all and more resonate as they do this election season. On today's program, we're going to be talking to two nurses, leaders from the New York State Nurses Association, and find out what frontline nurses are saying about the future of healthcare in our country. Judy Sheridan-Gonzalez is the president of NYSNA. Is that how you pronounce it? Yes. NYSNA. She's also an ER nurse at Montefiore Medical Center in the Bronx. Pat Kane is executive director of NYSNA. She's worked in the operating room at Staten Island University Hospital, Northwell Health, for more than 2 decades. So both of you, thank you so much for coming in.
Thanks for having us.
You're nurses and you head up an important organization, so you're busy. The most important thing I think I want our audience and me to learn in this conversation is what you're up against. Like, what are you seeing in the hospitals? So can we just start there? We sometimes talk about healthcare without remembering we're talking about people. Pat, do you want to begin?
Actually, this flu season is the first time we've seen at the hospital I work at that we actually have what we call hallway patients. So, I mean, the emergency room always has patients in the hallway, right? But this is a situation where patients are admitted, and they're admitted to the floor, but they're actually not admitted to a room.
But you're an operating room nurse. Don't tell me they're operating in the hallway.
No, we haven't gotten to that point.
What are you saying?
Well, I work in an emergency room, so it's a very busy emergency room. I also happen to work in the county with the worst health indices in the entire state. We have huge asthma population, very often related to the pollution in the community as well. But the emergency rooms are overwhelmed. Our emergency room is one of the busiest in the nation, and we could have 30, 40, 50 patients waiting for a bed upstairs. And as Pat said, we were the pioneer in hallway patients. We can have 7 or 8 on a unit, patients who are on stretchers with a screen protecting them, no bathroom, no anything. These hospitals have closed beds. They continue to close beds and close hospitals. This is unconscionable because you close 2 or 3 floors and you have 60 people waiting in the ER, 7 up on a floor in a hallway. It's all about making money. It's not about caring for patients, and we are overwhelmed. People lack primary care, and waits for specialty appointments and even primary care appointments are way too long. So people come to the ER for their primary care and very often delay care until they're really sick.
So typical nurses, you've talked about the impact on patients, but what about the impact on you and your colleagues in the union and not in the union?
Well, we're exhausted, we're overwhelmed because of the frustrations that our patients face, because of the lack of care for mental illness. There's a lot of violence. We're the recipients of the frustrations, the anger, the psychoses that people suffer. And people are afraid sometimes at work, particularly in our frontline areas like the ERs and the clinics and our mental health floors. People are frustrated and waiting long waits, not getting the care that they need. The way the current healthcare system works to treat mental illness, for example, very, very underserved. They're very short admissions where there used to be longer admissions. In terms of the support, there's not the counseling. People are over-medicated, under-medicated. There's many issues with that, and in addition, people just don't have the services that they need, so they're very frustrated at the time in which they seek care.
So the nurses are really feeling the brunt.
And I think it's hard for us to retain nurses. You know, a lot of nurses get out of school, and our education is great. It's a great science, and some would say an art as well. It's really a holistic view of taking care of a person, and they get out into a facility and they're just overwhelmed with the number of patients that they are expected to provide care for at the same time. And we have a standard, right, that we are ethically obligated to practice by. And especially for new nurses, that can be really devastating. And a lot of a lot of them leave, you
So
know,
they
after
get
they've made a great
exasperated that they
investment.
can't give the care they know they are supposed to be giving, they want to give?
Yeah, they get exasperated, and it almost feels like a moral dilemma, you know, that, and it's very stressful to feel that way, to feel like you're not doing everything you should have done, or even just second guessing, did I give the right medications to these patients? I mean, when you have patients in a hallway or patients on top of each other, you know, the potential for errors is very great. I mean, and I think to our nurses' credit, they're able to hold it down, but they're doing so at a great, great price to themselves.
So on top of that, you encourage them to be active in their union. Do they have time and energy for that?
It takes a lot. You know, you say ask somebody to do something, you get a busy person.
Yeah.
So a lot of our activists are doing other things around social justice and other areas that we're also concerned with. But the issues in the facilities themselves, particularly in direct care with direct care providers, has to do with understaffing, a lack of resources, a lack of training, and now we have this additional burden with the electronic medical record. Many people complain that nurses, physicians, other providers are constantly on computers or phones instead of touching them.
Yeah.
That's moved us away from the gift that we give to people, which has to do with human interaction.
So that's the flip side of what we've heard some politicians talk about: digital records. Have your records be able to follow you. It sounds good in principle, but
It's about billing. 90% of what we do has to do with billing. They've laid off a lot of clerical staff that used to do the billing, and that instead of us documenting care, we're really documenting things that we do, and so that the patients can get billed. A lot of checklists, and I think our documentation has actually, at least on the nursing end, has deteriorated because of that.
So to go back to the union thing, on top of all of that you've just described, you do have nurses in the union. How many do you have? Why do they join? And what do you offer them that makes it worth their while?
I think we're up to 43,000 just
Yeah.
about now.
Yeah.
We just organized about a year ago Albany Medical Center, which was a really big deal, 2,000 nurses. And that hospital has been tried to be organized before. So we do represent the nurses in the public sector that work for health and hospitals. And with the implementation of the Janus decision, what we found is we actually gained some members, because once the hospital started to have to give us better records, we actually went to folks who weren't members, and they were like, I don't know why I wasn't a member. I want to be a member.
So the Supreme Court decision barring automatic membership,
In the public sector.
has actually
Didn't hurt us.
benefited you?
Didn't hurt us at all.
No,
More
it
people
didn't.
joined the union.
Because you had to work harder?
Not so far.
I think because they believe, I think what people join a union about, or what they get most from a union, is having a voice in the work we do, demanding respect for what we do, being treated like human beings. There's a real incredible visual when you see the picture of Martin Luther King in Memphis before he died. What were they carrying? There were signs that said, I am a man. You know, people want to be treated like human beings, and the union provides a tool for them to utilize to be treated with respect, not only as professionals, but as human beings who deserve to be respected by virtue of being human and working.
All right, we're going to hear much more from Pat Kane and Judy Sheridan-Gonzalez from NYSNA, that's the New York State Nurses Association, after this. We're going to talk about what safe staffing might actually look like and why it's so important in negotiations. You're watching CityWorks.
The CUNY School of Labor and Urban Studies is the 25th and newest school under the CUNY umbrella. Dedicated to public service and social justice, the CUNY School of Labor and Urban Studies offers undergraduate and graduate degrees in the areas of labor studies and urban studies, and certificate programs in labor relations, public administration and public policy, healthcare policy and administration, and community leadership. We pride ourselves on being an institution that brings together activists and academics. Find out more at slu.cuny.edu.
Welcome back to CityWorks. I'm Laura Flanders here with two leaders from New York State Nurses Association about the future of healthcare. Let's get to that question of safe staffing ratios. There have been a bunch of union struggles in the last few years here in the New York City area and statewide, and people may have heard this term safe staffing. They've also heard ratios. This all sounds very, again, abstracted from humans. If you can just tell me what a safe staffing ratio might be and why it's worth fighting so hard for. Judy.
Well, there's so much data that proves that the number of patients that you take care of and it's common sense, allow you to give better care. You know, classrooms have limits, how many patients it's safe to, how many students it's safe to take care of. Daycare centers have limits. How many kids per caregiver there should be. In healthcare, it's the same thing. It depends on the level of illness, or acuity we call it, of a patient. In an intensive care unit, 1 or 2 patients. In a medical surgical unit, 4, maybe 5 patients. In step down and other kinds of areas, fewer, 3, and so forth.
So how many would you have in the ER? You work in an ER.
I've taken care of 15 patients or more at a time. It's pretty
Is that
dangerous.
safe?
Not safe at all, and it's definitely something that we struggled around in our last negotiations throughout 2019, trying to get better numbers in our contracts. But you know, the gold standard is getting it into the law, because there are many nurses that are not unionized in New York State, and patients in a hospital that is not unionized also deserve the best care. If we have it legislated, then the hospital is bound to provide enough staff to take care of patients so that they can get the care and the attention that they need.
I'm hoping that ratios are a little smaller in the operating room.
Yes, they haven't really found a way to have me take care of more than 1 patient at a time in the operating room.
But this still has been an issue that is so hard to win. And in 2019, you didn't quite get it. You got something else having to do with kind of consultation rights or workplace.
You mean in the contracts?
Yeah, in the contracts. Why aren't those other options sufficient?
I really think we need a baseline. You know, when you think about healthcare and all of the aspects of healthcare that are so regulated, and sometimes even over-regulated when it comes to what we were talking about before with the electronic medical record, it's really amazing that, you know, the thing that really affects the outcome of the patient's experience in the hospital, or their response to their disease, is not regulated. And that's the amount of patients that one nurse is responsible for at the same time. And
but why does it have to be in the contract? Couldn't it just, as some hospital administrators say, be better communications, better relationships?
We've done that, been there, kind of done that. I mean, we've been doing that for a long time. We've had safe staffing committees in our contracts forever and ever. And very often, you know, the excuses are the same. You know, we couldn't find anyone to cover. And Laura, if you don't have that baseline, if you don't hire enough nurses, get them trained up, and it takes time, right, to train nurses, to bring them on board and get them to that level that they need to function at. If you don't have the staff available, if you don't have that baseline, then you can't deal with, you know, epidemics, with just even the normal day-to-day, how patients' condition fluctuates throughout a shift even.
I mean, the direct care provider knows what the patient needs. You know, that we always hear that, well, the hospital administration has the overview. They have that understanding.
Yeah.
But when they want to give a report about what's going on in the hospital, they have to go to each floor. They don't say, here, I'm going to tell you what's going on. They say to you, what's going on?
Right.
What do you have? What do you need? But when you say what you need, you don't get what you need.
I'm assuming their pushback is, well, how can we regulate something that shifts? We don't always know how many people we're going to need. We wouldn't want nurses to be refusing to serve people.
That's why we talk about minimums. This is a baseline. The people who go to the hospital now are very sick. I mean, we used to stay 2 weeks after a hip replacement. Now people are being sent home almost the next day. Breast surgery, you know, all these kinds of things. People are going home. People are in same-day centers. People who are in the hospital are sick. So we have a sense, we know what the basic minimum could possibly be if all things are equal and there's no complications and there's no emergencies and the patient does as predicted, but people don't do as predicted. So our minimum is based on the best case scenario. The worst case scenarios which can occur is where we think there needs to be flexibility to have additional staff. But the hospitals won't even agree to that minimum, that baseline.
And that was one of the things that you fought about last year. You did win some other things. Do you want to talk about that? And then maybe why you think this is such a sticking point?
Well, in some of the contracts, we got a say into hiring. That there's mutual agreement about to where nurses could be placed. That was a plus. But I think in terms of the enforcement, you know, the hospitals, you can put stuff on paper. But like, for example, we have a law that says it's illegal to mandate people beyond their shift. It's a law against mandatory overtime. But there are hospitals that are violating that law all the time. You know, there needs to be some more strength in that law. So maybe I'm giving a bad example. But at least it really did change things from before the law went into effect, because the hospitals know that they're breaking the law. With the Department of Labor could you know, send them a letter. For staffing, we need some kind of regulatory mechanism as well, which is a really big deal. because then the hospitals would be forced to try to adhere to that, or the nurses would have tools that would enable them to fight it. We can do it in our unionized facilities, and we can talk about enforcing the language in the contract, but it really depends on the power of the nurses to be able to do that and their willingness to make that fight.
I just wanted to add something. In some of our contracts, we did get ratios this time around, though. I know in the Alliance, you know, they had a different, they kind of put it through money at the problem, right? They said, we'll give you X number of dollars. But actually, in some of our contracts and in health and hospitals, we did settle an agreement that actually does give them ratios. Now, there's a period of time for them to work to that ideal ratio, but that also has to do with recruitment and really some of the other enhancements they put in their contract to actually attract nurses. But we were able, I mean, I think the Alliance really kind of set a pattern. And after that, some of our facilities, we were actually able to get ratios in our contract. And there were one or two where we actually already did have them. So.
Yeah, we find also, I mean, again, you can have something in writing, but we find in our facilities where our patients are poorer, in our communities of color, in our areas where you have people who are chronically disadvantaged, the ratios are worse, in spite of what you have in the contract, because the hospitals say they don't get good insurance mix, but the patients should not be treated badly because of that, or treated worse. So in the hospitals that have plenty of endowments, plenty of money, or a good, what they call a good insurance mix, the staffing is better.
What the heck does a good insurance mix mean?
Private insurance. In my hospital, I think our Medicaid, Medicare mix is 82, 85%. There are other facilities that exist that Mount Sinai, New York Presbyterian, that have a very different payer mix, is how they describe it, which is why we also feel very strongly about Medicare for all.
I was going to say, so this brings us to Medicare for all, because as long as we are looking at supporting our hospitals, constituency by constituency, district by district, and our communities, our society is more segregated than it's been in decades, we can't have a health care that is equal for everybody. Why is this such a hard sell? Even among unions, why is this such a hard sell? Who wants to take a bite at that? You both get a chance.
Okay.
I think that for so long, when we've negotiated contracts in unions, we had the fights for health care, the fights for retiree health, the fights for support for health benefits for our families has been such a major battle. And people have sacrificed so much, wage increases, other things that people need to ensure that they have health care, both while they're working and when they're not working. It's very hard to think, oh, can I trust the government to do something for me when my union's done it for me? I think there's a kind of mentality about that. Also, there's, I think that's the biggest concern. How can I trust the government? I mean, the way that Medicare for All works is, if all of the facets of it are enforced, there's community input, there's labor input into what that should look like. And what would happen would be, I think the best way to look at it right now is people who have health care, let's say a family health plan that's good, costs $25,000 a year. If I make $50,000 a year and I want that plan, well, either through my union, my employer, or paying myself, it's $25,000 a year. If I make $2 million a year, I pay $25,000 a year. That's crazy.
Yeah.
So the whole thing about Medicare for All is that it would be a sliding scale, just like taxes, just like anything else, so that people who make more money would pay something out of the taxes. People who make less money would not. And all the economic studies that we've done shown that for the working class, for the middle class, people would be actually paying less out of pocket for their health care, and we wouldn't have the disparities that we have, and we'd certainly increase the primary care and the things that people need, so our ERs wouldn't be so overcrowded.
But I'm still stumped. Why is this such a hard sell? I grew up in England, so
Yeah.
I'm a convert.
So I just
why
think
is it so difficult?
I think part of it is the narrative that's out there, and certainly there are folks with very big pockets that spent a lot of money to put a certain narrative out there, and they have a lot of profit to lose, and they've really been profiting off the suffering of folks, right? I mean, if we have very good health coverage negotiated by our union, but if I got sick and I was out of work for 3 months, I would lose that health care. Yeah. So that insurance company gets to walk away with all that profit. I mean, I think when it comes to unions, because unions have negotiated such good health care, there's this fear of, I have really good health care, I don't want to lose anything, kind of like what Judy is saying. And I think part of what's been missing in the conversation is to really recognize labor's role, that labor has, for many years, basically ran these benefit funds and healthcare plans for their members. So maybe when we have these discussions, if labor was at the center of it and we looked at it like, hey, you know, labor really needs to be not just at the table, but really kind of be overseeing this whole process, I think that would really work, because labor has a lot of experience doing this to begin with.
Well, labor also has a lot of experience creating a we or an us out of a diverse group of people. And I can't help thinking that part of the resistance is about racism, sexism, those other people out there who will take more health care than they're entitled to and will somehow affect my ability to get health care. How much of a factor do you think that is, and how do we combat that?
Yeah, I saw this really interesting thing, I think it was on one of the television programs, where they showed this pie and wealth, and they asked people what they thought, because perception's a big deal, if this pie represented wealth of the nation, and you divided people into 20 percentages, right? How do you think it's divided? And people are saying, well, a half a piece goes to the bottom 20%, 2 pieces in this one, and when people saw that there was only half a slice left after the top 10% got what they got, and out of the top 10%, the top 1% got 90% of that, and that by the time you went down to the bottom 40 or 60%, there were only crumbs left, and that was how wealth is distributed. I think it's the same concept.
Yeah.
You know, the savage inequities that exist in our society are so manifested in healthcare, and the kind of healthcare people do and don't receive.
And racism?
And absolutely racism, because race is so much tied to class and
xenophobia.
The history of this country, and the xenophobia and the anti-immigrant sentiment and all the kinds of things that people feel threatened by, when basically most people in this country were immigrants.
Because you have just described a situation of a certain amount of scarcity. There's not enough treatment, there's not enough people, there's not enough resources. It's no surprise that people feel there's scarcity. I want to hang on to what's mine, not share, not change, not give to people that might not be deserving.
I think the thing to understand is that the scarcity is because of the broken system, right? If we did have a more equitable system, and if we did have a single payer system, we wouldn't have a lot of those scarcities, even when it comes to medications, when it comes to staffing, and the other things that we talk about. And that, I think, is also part of when people talk about, oh, people are going to lose jobs if we go into this kind of system. There are going to be jobs in different, I think jobs are going to be different, right? Instead of being at a job where you're really trying to deny people care every day, you're going to actually be in a job where you're trying to help people get better, which is, you know, might be nice. And I'm not even just talking about direct care. I'm talking about a lot of other things that would be needed and would be better utilized. I mean, if you look at what's going on in New York right now, I think it's really evident that we can't go through this every budget cycle with looking at Medicaid and looking at a deficit. We have 30% of the population in New York State on Medicaid, and there's also...
And yet the governor wants to cut it, $2.5 billion.
The governor wants to cut it, and cut it with just saying we have to do this, right? Not really thinking about other things. For every dollar for every like 40 cents that we cut, we'll actually lose $1 because of the federal matching funds.
We have to close, but I have to ask you, would NYSNA ever strike?
We've had strikes. There was a unit that went on strike in New Jersey. And this is so indicative of this whole issue about the privatization and consolidation of healthcare. There is a facility, Shore Memorial in New Jersey, that made $26 million extra over the past 2 years, and they were asking nurses to increase their premiums by thousands of dollars, increase a per visit pay to $70, offered a 0.75% raise to nurses. The nurses in that area are near Atlantic City, and nurses who had been cocktail waitresses in Atlantic City had better health care than the nurses who worked in that facility. Those nurses did go on strike. And of course, you know, as a last resort, that's what workers do. That sort of makes the rubber meet the road when you're dealing with...
And just one, I think it was kind of interesting because I heard the name mentioned a few times. So the CFO of that hospital was actually a former person that was part of Trump Entertainment around the time when the casinos closed in Atlantic City. And he's actually CFO of that hospital.
And last question, people will never forgive me if I don't ask you, what is the reality about coronavirus? How worried should we be, and do we need to wear masks?
I think people who have suspected of having coronavirus definitely have to wear masks. I don't think people have to wear masks everywhere they go. It has to do with travel. It's you know, definitely spreading from a particular area. And we have guidelines that the medical response team and the state has put forward that in our emergency rooms and areas of entry is where we have to be careful. I don't think people have to wear masks everywhere they go.
Thanks to Judy Sheridan-Gonzalez, president of NYSNA and an ER nurse at Montefiore Medical Center in the Bronx, and Pat Kane, executive director of NYSNA. That's it for this month's edition of CityWorks. If you have comments or suggestions, write to cityworks@slu.cuny.edu. For CityWorks, I'm Laura Flanders. Thanks for watching.